some flavor in the last slide about the classification of antibiotics. Did he? That how many classes of antibiotics are there? Basically, based on the structure and function we have identified in the prokaryotes in bacteria, which are quite different from the eukaryotes in the human cells. Okay, are you familiar with the term selective toxicity? Selective toxicity. What is that?
Toxicity for a specific antibiotic. So if we increase the dose, we will have like a specific side effects or toxicity.
No, it is not selective. Selective toxicity is the term applied in the antimicrobial drugs. The drugs, antimicrobial drugs, are selectively toxic to the microorganisms, but are not affecting or minimally affecting the human cells, the host cells. So we achieve this selective toxicity in case of antibiotics mainly. The reason is we target the structures, functions in the prokaryotes which are not present in the human cells. So in that case, the receptors, the structures which are only in the prokaryotes, effect will be on those structures and the human cells will be spared. So this is the concept behind selective toxicity, the toxic to a particular organism, but non-toxic to the other organism. In case of antibiotics, only prokaryotes or bacteria. So in order to achieve that selective toxicity, you have to target certain things. See, what are the differences? Cell wall. Cell wall is not present in human cells. It is only in bacteria. Okay, this is one structure. Other is protein synthesis machinery, which is quite different in bacteria compared to the human cells. In human, it is ATS ribosome, 40, 60 subunits. In bacteria, it is 30 and 50, isn't it? So it is different. The structure is different. Mechanism is similar. Process is similar. But the structures are different. Ribosomal structures are different. And then there are certain enzymes. There are certain metabolites like folic acid. They are different. You think, what are the differences? You utilize, manipulate those differences so that the drug is not toxic to the human cells, but toxic to the bacteria. So the biggest chunk of drugs which are widely used are the drugs which target specifically the cell wall. Okay. Today we will discuss the cell wall synthesis inhibitor classification and structure activity relationship of beta-lactam antibiotics. We'll discuss one by one. And someone from microbiology, I'm sure, must have told you by now the structure of cell wall, the structure of cell wall, especially the peptidoglycan, isn't it? So now we will build on that information in the context of antibiotics and mechanisms of drug resistance against beta-lactam antibiotics and beta-lactamase inhibitor, and then clinical uses and adverse effects of beta-lactam antibiotics and vancomycin. So classification, we already mentioned, Dr. Hakim mentioned already. Let's start with cell wall synthesis inhibitor, one of the most important class of antibiotics. Now, you can see they are basically divided into two major classes. The biggest class is beta-lactam antibiotics and other is non-beta-lactam, only one drug in this class. There are few unimportant drugs in this class, but let's focus on only one drug, which is vancomycin. All the other cell wall synthesis inhibitors belong to beta-lactam. Now, what does it mean, beta-lactam? Beta-lactam.
The organization of the cell wall and the bacteria.
No, it is the structure, functional group, chemical structure of the beta-lactam antibiotics, which gives the name to the whole class. I will show you the structure, chemical structure of this whole class. All the drugs contain beta-lactam ring, which confers the drug the bactericidal activity. Without beta-lactam ring, the antibiotic is no more an antibiotic. It is a beta-lactam ring present within the structure of the antibiotic which provides antibacterial activity. So all the drugs which contain beta-lactam ring in its nucleus, in its structure, they are known as beta-lactam antibiotics. Again, beta-lactam antibiotics are divided into four subclasses. Penicillins, I'm sure you all know about penicillins, cephalosporins, carbapenems, and monobactams. And based on the antimicrobial activity, cephalosporins are once again subclassified into first, second, third, and fourth generation, mainly. We'll discuss one by one what are the differences. So is that clear up to now? Beta-lactam, non-beta-lactam, and one drug in non-beta-lactam, vancomycin, all others are beta-lactam cell wall synthesis inhibitors. Penicillins, cephalosporins, carbapenems, and monobactams, and four generations of cephalosporins. Okay. Beta-lactam antibiotics, four classes. Penicillin was the first member of this group, beta-lactam antibiotics, which was invented and used later on just before World War II. Okay, it was incidentally found. Sir Alexander Fleming from UK, he was professor of bacteriology. He was actually culturing Staph aureus, and he found some contamination of a mold in Staph aureus while culturing. He said in certain places the bacteria did not grow in the petri dish. Bacteria did not grow at other places. Bacteria grew in the culture. Why? What happens? Staph aureus I cultured here, but they are not growing. So there is something which is preventing the growth of bacteria in the petri dish. And he found out the culture plate was contaminated with a mold, Streptomyces. And from there, he thought that something is present in this mold which is inhibiting the growth of bacteria, other bacteria, Staph aureus. So he isolated a drug and called it penicillin. Did you find this? This is incidental finding. So he noticed some zones of inhibition where mold spores were growing. He named the mold penicillinum, and it was determined that those fungi, yeast, they are actually secreting a drug, penicillin, which is inhibitory bactericidal to other bacteria. So, as I mentioned, this beta-lactam ring, three structures, thiazolidine ring, beta-lactam ring, and not less important, equally important is the side chain. See, penicillin, beta-lactam ring, thiazolidine ring, and this is the whole side chain, and this is the side chain actually, which is very, very important in determining the pharmacokinetic property of the beta-lactam antibiotics. Now you see there are so many beta-lactam antibiotics. Some are effective against gram-positive, others are effective against anaerobes, others are effective against gram-negative, some are effective against pseudomonas. Why this difference? It is a property of the side chain which determines how the drug will behave in the system. Will it penetrate inside the bacteria or not? Will it bind with the receptor or not? Will it be destroyed by the beta-lactamase enzyme or not? So these are the properties which are conferred by the side chain. Bactericidal activity is conferred by the beta-lactam ring, but the properties of the antibiotics are conferred by the side chain. Keep in mind, this is one of the learning objective structure activity relationship of beta-lactam antibiotics. Beta-lactam, thiazolidine, and side chain. Now, briefly, who delivered the lecture? Mohabbat or Hana on self? Hmm? Hana. So she must have clarified. Cell walls of bacteria are essential for their normal growth and development, obviously. Peptidoglycan is a heteropolymer component of the cell wall that provides rigid mechanical stability by virtue of its highly cross-linked lattice work structure. Now, before actually going into further, I must give you some analogy example, practical example. Let's example, this is cotton. It's thick, rigid, very tough. What is the structure? How it is made of? Of what? Cotton, yarn, threads, fibers, cotton fibers. They are interwoven together to make cotton fabric. And that yarn is made of what? Cotton yarn, thread, fiber is made of what? Very tiny particles of cotton, cotton balls. Have you seen? Very soft. You can easily break them. Cotton. Those fibers are joined together analogous to polymerization. Polymerize to make a cotton yarn. This yarn is still softer. You can break it. Fiber, thread, you can break it. It's still soft. But when you interweave it, weave it together, it becomes tough and rigid cotton fabric you can wear for your protection, protect your body. So similarly, peptidoglycan as per se, it has been told to you by the microbiologist, it is a thick, rigid polymer of various amino acid residues, which gives a mechanical rigidity to the cell, bacterial cell. But within that, it contains various amino acids, which are cross-linked. You need to understand the process of that cross-linking in order to understand the mechanism of action of cell wall synthesis inhibitors. The peptidoglycan is composed of glycan chains, which are linear strands of two alternating amino sugars, N-acetyl-glucosamine and N-acetyl-muramic acid, match name entropy. I'll show you the figure. See, cross-linking. And this cross-linking is achieved by a family of enzymes. Did Mohabbat Hana tell you what is the name of that enzymes which achieves this final step in the cross-linking of this amino acids? Hmm? Transpeptidase. Very good. It causes the cross-linking of those polymers of these amino acids. Polymers are arranged like fibers, and then they are cross-linked to make peptidoglycan tough cell wall, which is component of cell wall. Now, that transpeptidase originally, from the pharmacology perspective, I can tell you when Fleming was there, before World War II, the structure of transpeptidase was not known. We didn't know that it is transpeptidase, what is the function. The only thing which the pharmacologists of their time knew that this is penicillin obtained from Streptomyces yeast, which has the ability to bind with gram-positive bacteria and produces its bactericidal action. So without knowing no electron microscopy, you know nothing, no technology, but at least they knew there is some site on the cell wall of the bacteria which provides attachment to the penicillin receptor. So they broadly called it PBP. What does it mean? Penicillin binding proteins. Penicillin binding proteins are basic. This is the original name. But then later on, with the advancement of technology, it was found out that PBPs are nothing but the transpeptidase enzyme. So they are synonymous. PBPs and transpeptidase are synonymous. So it's the last step in peptidoglycan synthesis that is inhibited by the beta-lactam antibiotics. PBPs are transpeptidase. They bind with the active site of this enzyme and inhibit it. And beta-lactam irreversibly inhibits the enzyme by reacting with the serine residue. Now you can figure out very well if that enzyme, which is responsible for the cross-linking of those Polymers, if it is inhibited, it will be just long strands of fibers which will not give rigidity or mechanical support to the cell, isn't it? In that case, cell wall synthesis is inhibited, cell becomes osmotically fragile. Cell becomes osmotically fragile, and the trans, movement of transmembrane ions, water will cause the cell to burst, and it is not compatible with life. Immediately, the cell will be destroyed because cell wall is important in maintaining the integrity of the structure of the cell. So, in this case, eventually the growth of the bacterial cell was inhibited in the presence of beta-lactams. Autolysins are also released, causing the lysis of the bacteria. I don't want to confuse you because we don't have much time. Simply, this is synonymous with the apoptosis process. When the cell wall is defective, it is not compatible with life. Autolysins are released and the cell dies. Khalas. No more. Apoptosis. So inhibitory effects of beta-lactams we discussed. Let's move. What is selective toxicity we discussed? Are you clear about this? So the selective toxicity of beta-lactam is achieved because they target cell wall, which is not present in the human cell. Obvious. Peptido, we discussed. So that is why beta-lactam antibiotics are practically non-toxic to man because no peptidoglycan, no PBPs in humans. So penicillins are, so this we are talking about all beta-lactam antibiotics, mechanism of action. Penicillins, cephalosporins, monobactams, and carbapenems. Okay, all four classes. Vancomycin is slightly different, non-beta-lactam. Natural penicillins, like benzyl penicillin, gram-positive, it is effective against gram-positive cocci, anaerobes, and selected gram-negative rods. Penicillinase-resistant penicillins, flucloxacin, cloxacillin. Are you familiar with the term MRSA? Not yet. Methicillin-resistant staph aureus. Just we'll touch later. So these are penicillinase-resistant penicillins, aminopenicillins, which have some extended spectrum, very commonly used, amoxicillin, ampicillin. Are you familiar with these drugs? Amoxicillin, ampicillin, widely used. And some penicillins are anti-pseudomonal. They are effective against, not all penicillins are effective against Pseudomonas aeruginosa. Some are like tecarcillin and piperacillin. You haven't taken lecture on the terminology of bacteria, Pseudomonas, staph, strep, not yet. Not yet. Gram positive, up to now gram positive. Okay. Pharmacokinetics of penicillins. Most penicillins are eliminated via tubular secretion, with secretion blocked by probenecid. Probenecid is a drug which blocks the secretion of penicillins from the glomerulus. What will be the implications? Penicillins are excreted from the kidneys through secretion. There is one drug which inhibits the secretion of penicillins and it is not excreted. What will be the implication? The plasma concentration of the penicillins will become high and it will remain in the system for prolonged period of time. So whenever you want a drug to have longer half-life, increased duration of action of penicillin, you can co-administer probenecid along with it to increase the half-life of the drug, to increase the duration of action of the drug. These are the implications of co-administering penicillin with probenecid. Penicillins cross the placental barrier. Once again, no effect, no teratogenic effect, very safe during pregnancy, no issue at all. Patients with impaired renal function must have dosage regimens adjusted. As I mentioned, they are excreted through kidneys. Neficillin and oxacillin are two exceptions among the penicillins, since they are primarily metabolized in the liver and do not require dose adjustment for renal insufficiency. How the drug can be? Now, Dana must have told you, did she cover metabolism and excretion? Or Hatu? What are the roots of excretion? Mainly liver. So here, few drugs are excreted through liver, through the bile. Uh, I just named you about metabolism and liver. No, no, in a good way, in a good way. Okay, see. So some drugs, very few, not many, are excreted through bile and in the GID, and some under they come back. They come back, and this is known as enterohepatic circulation. Entero means intestine, hepatic means liver. They are excreted through bile. They come back through portal circulation, and they make a loop between liver and intestine. This is known as enterohepatic circulation. But eventually, they are excreted through GIT. So kidney does not play an important role in the overall excretion of the drug. In that case, even these drugs, nephicillin and oxacillin, can be given, I mean, without any fear in the patients with renal failure. Is that clear? One drug which merits attention, which you will cover in CVP block in detail, is the benzathine penicillin, which is a special penicillin. Benzathine penicillin is a special penicillin. Its half-life is 2 weeks. The effect of that drug persists for about 4 weeks, 1 month. Would you want that antibiotic to remain in the body for 1 month? No. Sometimes you want. Especially in the prophylactic treatment, there's a disease you will learn in CVP block is the rheumatic fever. For about 5 to 15 years, you administer penicillin as prophylactic to, from the streptococcal infections. So this drug, benzathine penicillin, is long acting. It is given intramuscularly and it is absorbed very, very slow into the systemic circulation and it persists in the body for about 4 weeks. So every month a single dose of intramuscular injection is given for several years to prevent the streptococcal infection. You will learn later on, but just to tell you that there is one preparation, a special preparation, which has long duration of action, which is benzathine penicillin. Okay. Now, clinical uses. Who will tell me clinical uses? Of penicillins? Personally, I avoid using the, I mean, writing the names of the diseases in case of antibiotics. Because in the case of clinical use of antibiotics, it is basically dependent upon the etiological agent. It can be sometimes the same pneumonia can be caused by gram positive, can be caused by gram negative. Same meningitis can be caused by gram positive, can be caused by gram negative, or so many things, anaerobes. So in that case, writing here pneumonia will be misleading. Pneumonia due to susceptible organisms, meningitis due to susceptible organisms, am I right? Yes. So in that case, the only indication would be the drug, all those penicillins can be used in any of the infection caused by the sensitive bacteria. That's it. We can't write the name of the disease because the same disease can be caused by a variety of organisms. So I purposely avoid writing the names of the disease. Yeah. Okay. Just I actually focus on you to have idea about the antimicrobial spectrum. This antibiotic, penicillin gene, is effective against gram-positive. Aminopenicillin is effective against some gram-positive and some gram-negative. Tecarcillin is effective mainly against Pseudomonas aeruginosa. This is the way to memorize the clinical uses of the antibiotics, antimicrobial spectrum. Yes. Spectrum means spectrum antimicrobial. When we talk about antimicrobial spectrum, that means name the bacteria against which this antibiotic is effective. The spectrum. Gram positive disease, gram negative disease, anaerobe disease. okay, against which this particular antibiotic is effective. Adverse effects, as I mentioned, generally it is safe because it is selectively toxic, but of course it is a chemical. It is a chemical. It has, apart from the mechanism of action, it has some other effects. The most important is hypersensitivity reactions, allergic reactions. Most common, it can be very mild, some skin rashes, ranging from skin rashes to the anaphylaxis, which can be very, very severe, sharp, and can be fatal. So, in so there's a whole spectrum of allergic reactions. The overall incidence of such reactions to penicillins is low, and keep in mind there is cross allergenicity among all penicillins. What does it mean? Cross allergenicity. Figure out.
Allergy.
Cross allergenicity.
Maybe it is yani, used to be treated as against it like allergy.
Yeah. If you are hypersensitive, allergic to one penicillin, Murphy's law says that you are allergic to all penicillins, cross allergenicity. If you have been found in one instance that you have developed anaphylactic shock to one penicillin, let's assume that you will develop the same reaction to all penicillins, cross allergenicity. Okay? So this is known as, if you are allergic to one, you are allergic to the whole class of, whole range of penicillins. This is cross allergenicity. Rarely bone marrow depression, granulocytopenia, hepatitis. Okay. Mechanisms of bacterial resistance, how the bacteria develop resistance. Now keep in mind a magic sentence which you have to memorize all of your life whenever you try to understand the mechanism of resistance. In order to be effective, an antibiotic must reach at the site of action in active form and should bind with its receptor. What are the keywords here? First keyword, should reach at the site of action. If it does not reach, it is no more an antibiotic. It reach at the site of action. The second form, second keyword, active form. It has to be in active form. Whenever you gave, it has to be in the such form without any modification. And the third is bind with the receptor. If anything happens in these three keywords that confers resistance within the bacteria towards that particular antibiotic, and all from now on, Dr. Hakim will tell you in protein synthesis inhibitor, Hatif will tell you in antimetabolites, all the antibiotics which, I mean, the bacteria develop resistance against those antibiotics through one of these three mechanisms, three keywords. Either the drug does not reach, either it is not active at the required site of action, or it cannot bind with its receptor. Now, based on these three keywords, the mechanism of resistance to penicillins and to all the beta-lactam antibiotics is having. Some are natural, we are talking about acquired. Natural resistance, some bacteria do not have cell wall. Are you familiar? What are those?
Mycoplasma.
Mycoplasma. Obviously, natural resistance. They don't have peptidoglycan. They don't have cell wall. So it will be irrational to use beta-lactam antibiotics against mycoplasma. Natural resistance. Acquired resistance to penicillins and other beta-lactams is due to one of the three general mechanisms which I described in the previous slide. Three mechanisms.
And active form.
Inactivation of the antibiotic by the beta-lactam, most common. The drug does not reach now in the active form because what did I say initially? The drug must have intact beta-lactam ring to produce antibiotic activity. If beta-lactam ring is destroyed by the beta-lactamase enzyme, the drug is no more antibiotic. Now, the first, that attribute of the drug does not reach in active form, is gone. Bacteria are resistant. Other attribute is modification of the target PBPs. The drug must reach in active form and bind with the receptor. Now, if the receptor is changed, the chemically the receptor, the structure of the receptor is changed. The drug goes in active form and finds where to sit. There is no seat. The seat is changed. The receptor is changed. Now, PBP's transpeptidase enzyme, they do not provide a binding site for the beta-lactam antibiotics. Does not bind with the receptor. Is this concept clear? Second attribute is gone. The drug is active. It reaches there, but can't bind with the enzyme. The third is does not reach at the impaired penetration of the drug to the because the drug must enter the cell wall and act from within inside to bind with transpeptidase. If drug does not enter because of the this is why many of the conventional penicillins are not effective against gram negative because the structure of gram negative is inner cell membrane and outer cell membrane, which is quite tough, which is impermeable to the penicillins. So the drug must enter and bind with the transpeptidase in active form. If not, the bacteria are resistant. Is there any question from the audience or not? No. So they are sleeping or they are not there. Any question up to now? No? So this is the site of action of penicillin, penicillinase or beta-lactamase, where this structure is destroyed because of the certain enzymes produced by the bacteria and the antibiotic loses its effectiveness. It is no more an antibiotic. Now, in order to overcome this situation against bacteria which produce beta-lactamase, we have some, because we are human beings, so we have some clever ideas. We made beta-lactamase inhibitors. Okay? Beta-lactamase inhibitors are the drugs which themselves, they are not antibiotics. Themselves, they are not antibiotics, but they resemble antibiotics and they present themselves to deceive beta-lactamase and bind with beta-lactamase enzymes. They present themselves as suicide commandos, suicide bombers. At least by suicide action, they spare the antibiotic penicillins. Now it is free. They accumulate, they saturate all the beta-lactamase enzyme produced by bacteria. Now the antibiotic is free to act on the cell wall. When the mechanism of resistance is due to production of beta-lactamase, we can combine beta-lactamase inhibitors along with penicillins so that the penicillins are now free to act on cell wall because beta-lactamase was inhibited by the beta-lactamase inhibitor. And we have three drugs, very famous drugs. I'm sure all of you know, especially about the clavulanic acid. Are you? You know? If I tell you the name of the drug which is available commercially, oh yeah, that is the drug, clavulanic acid. Have you heard about augmentin? Hmm? So augmentin is basically the one which is the combination of clavulanic acid and amoxicillin. Amoxicillin alone in bacteria producing beta-lactamase will be ineffective because it will be destroyed by beta-lactamase. But combined with clavulanic acid in the formulation augmentin, it will be still be effective because beta-lactamase will be inhibited by clavulanic acid. So there are three beta-lactamase inhibitors, but we will more concentrate at this level on this combination, co-amoxiclav or combination of clavulanic acid plus amoxicillin. Any question? Yes.
Doctor, why would we use an inhibitor for beta lactam while يعني إنه the beta lactam is found in the drug?
No, we are not calling it beta-lactam inhibitor. Beta-lactamase inhibitor.
Yeah, but I mean beta lactamase isn't found in a drug.
No, beta-lactamase is an enzyme produced by certain bacteria to overcome the beta-lactam antibiotics. They destroy beta-lactam ring. Now, in that case, if a bacteria is producing beta-lactamase enzyme, your beta-lactam antibiotics will become ineffective because the beta-lactam ring will be destroyed, isn't it? So in that case alone, amoxicillin, for example, will be useless. As soon as it will interact with the bacteria and the bacteria will secrete beta-lactamase, amoxicillin is gone. Beta-lactam ring will be broken, hydrolyzed. In that case, if you combine amoxicillin with clavulanic acid, clavulanic acid is not antibiotic itself, but it will inhibit the beta-lactamase which is coming from the bacteria. And then now amoxicillin is free to produce its antibiotic action. Not clear?
Yes.
Is this concept clear? Good. So now let's move to cephalosporins. Mainly, we covered many things about in penicillins, which are the same for cephalosporins. Mechanism of action, side effects. The only thing different is antimicrobial spectrum. Antimicrobial spectrum, because of the chain, side chain is different. It confers how the drug will behave with the bacteria in the body, how it will reach in the CNS, how it will reach. Because didn't I mention three things? Thiazolidine ring, beta-lactam ring, and the side chain. Side chain will actually determine how the drug will be handled by the body, by the bacteria. So there are basically in the textbooks it is fourth generation, as I mentioned in the earlier slides, but a new drug has recently come, but the terminology fifth generation is not so much widespread, but I have mentioned it. First, second, third, fourth, fifth generation drugs. And I have mentioned in the second column one or two examples of this generation: cephalexin, cefaclor in the second, ceftriaxone in the third, cefepime in the fourth, like that. And spectrum, as I mentioned already, against which bacteria these drugs are effective. First generations are mainly some gram positive and some gram negative. The spectrum resembles with that of aminopenicillins in the previous slides. Do you remember? Aminopenicillins, amoxicillin, and ampicillin, two drugs. So this antimicrobial spectrum resembles very well, and few Klebsiella proteus gram negative. As you increase the generation, second generation, they are less effective against gram positive, but generally more effective against gram negative, increased gram negative. Now more H influenza, you will learn next week from microbiology people. You increase the generation, third generation, now it is more or less gram negative, third generation. Okay. And fourth generation, in addition to the third generation, they are also effective against some gram positive, and they are very, very resistant to beta-lactamase enzyme. Now, the million-dollar question is, why beta-lactamase resistance fourth generation? What is the reason? Once again, recall, I mentioned you, it is a function of the side chain. In the 3D structure of the beta-lactam antibiotics, the side chain encloses, prevents the beta-lactam ring from the action of beta-lactamase, so it safely reaches the bacteria from inside and produces antibiotic activity. So it is basically the tough, lengthy, bulky side chain of the antibiotic, which prevents the beta-lactam ring from the destructive action of beta-lactamase enzyme. Fifth generation, additional property, it is effective against MRSA, methicillin-resistant Staph aureus. So you have to memorize this spectrum very well. It will be easier for you to memorize once you receive some lectures from the microbiology people, know the difference between gram positive, gram negative, some familiarity with Klebsiella, Haemophilus influenza, Pseudomonas aeruginosa like that. It will be easier for you later on. Okay? And MRSA. Carbapenems, oh, similar, two drugs, Imipenem and Meropenem in this class. Once again, we are talking about beta-lactam, isn't it? The third class, penicillins, cephalosporins, carbapenems. You can read on your own. We don't have much time. The only property of this drug is imipenem. If you give alone, only imipenem, it is ultra short acting. As soon as the drug is given in the body, it is immediately destroyed by an enzyme present in the kidney, the known as dihydropeptidase 1 enzyme. As soon as the drug passes through the kidney, it is hydrolyzed. So the drug becomes having extremely short half-life. You have to go the drug 10 times a day, 8 times a day, which is impossible. Giving intravenous drug 8, 10 times a day. So once again, we have clever ideas to counteract this thing. Give a drug, another drug along with imipenem, it is always the combination comes together. Celestin and imipenem, they come together in the same thing. They are given together. And the celestin, no antibiotic effect, just an inhibitor of this enzyme. This enzyme is inhibited, the drug is not destroyed, the, the duration of action becomes longer. Now, once a day is okay. Once a day is okay. So the combination actually increases the half-life of the drug. Clear? Otherwise, they are the same. You can read on your own. I will go directly to the monobactam. Primarily the fourth class of the beta-lactam, primarily active against aerobes and used in severe sepsis, often hospital required. Similar things. I already asked this question when we say that beta-lactam is essential for the antibacterial activity of the group, which is shared by all penicillins, cephalosporins, and others. Why the antimicrobial spectrum is different? Now you know, because of the side chain. Because of the side chain. Last but not the least, few minutes on vancomycin, the only cell wall synthesis inhibitor which is non-beta-lactam. Obviously, the mechanism of action is different. Now, before going into slides, I just explained to you the same analogy. Fiber, fabric, cotton fabric, peptidoglycan. It is made from the polymers of yarn. Yarns are polymers of small cotton pellets or particles. So the yarn has to be made first. After that, it has to be cross-linked to make weaving, to make fabric. Same is with peptidoglycan. Didn't I mention peptidoglycan thick wall before cross-linking, before transpeptidation, the, before that step, there's a polymerization of amino acid residues. That polymerization step is inhibited by vancomycin, not transpeptidation, but eventually it will be the cell wall synthesis inhibition, isn't it? Because polymers are required for the interweaving. If polymers are not available, then the cell wall synthesis will once again be inhibited. So vancomycin inhibits bacterial cell wall synthesis by inhibiting peptidoglycan polymerization. The keyword over there, cross-linking of polymers by inhibiting transpeptidation. Now, before that step, polymerization, that is inhibited by vancomycin, which is a step earlier than that inhibited by the beta-lactams. It is effective mainly against MRSA. Now, this is very important concept, and ask me if you don't understand. One of the mechanism of resistance against beta-lactamase was the drug must reach at the target site must reach at the target site in active form and bind with the receptors. And one of the mechanism was not binding with the receptor, as I mentioned, because the target proteins are changed. PBPs are changed. Now conceptualize those bacteria which have become resistant to beta-lactam antibiotics because they have changed, they have modified the PBPs. Will they be affected by vancomycin or not? Because they don't require, vancomycin does not require PBPs, does it? That is why MRSA, which is methicillin resistant Staph aureus, that will be covered in detail by Elizabeth later on next week. She must have covered this week. Gram positive. Okay, maybe next week. So MRSA, methicillin resistant Staph aureus is the one very unique bacteria which develops resistance to beta-lactam antibiotics by virtue of modifying its PBPs. So all beta-lactams become ineffective against MRSA. In that situation, when the mechanism of resistance is due to change in the structure of PBPs, vancomycin is effective because vancomycin does not require PBPs. Is that clear? So vancomycin is reserved. It's a treasure. You just keep in the locker. Don't use injudiciously. It is very, very effective drug against MRSA. So it is not absorbed from the gut and is usually given as an intravenous infusion. Adverse effects, hearing loss, venous thrombosis, red band syndrome due to cytokine histamine release following rapid intravenous administration as soon as the drug is being delivered intravenously. Within minutes, you will see the person has become red who is receiving the drug. This is known as red man syndrome, hypersensitivity, nephrotoxicity. So that's it. Any question? No? Yes,
Penicillin acts in transcriptase, right?
correct.
Gram-negative didn't have transcriptase. So how does it act in a gram-negative?
They have, they have. Peptidoglycan is important constituent of all bacteria, gram positive as in gram negative. The only difference is in gram negative, they do not stain with gram because it is because of the peptidoglycan which stains violated in gram staining. But gram negative, if you look at closely the structure of gram negative, the peptidoglycan is heavily hidden. It is not from the outside. Because outside the peptidoglycan layer, there is an outer cell membrane in the gram negative. That prevents gram negative bacteria from staining violet with gram stain. Otherwise, they have peptidoglycan. But compared to the gram positive peptidoglycan, in the gram positive bacteria, peptidoglycan is thick. In the gram negative is thin and it is prevented from the outer cell membrane. That is why you stain differently gram positive and gram negative, but peptidoglycan is there in gram negative. Who told you that peptidoglycan is not there?
Because you said there's no link between the amino acid, the gram-negative.
Who told you?
Slide, or I misunderstood it because
Peptidoglycan is exactly the same in gram positive and gram negative structure, as far as structure is concerned. The only difference is the different layers. In the gram positive is a thick and it is the outermost layer of peptidoglycan. That is why that layer of peptidoglycan in gram positive gives the property during gram stain. It stains biliary. Whereas in gram negative, it is inside. Outside covering is outer cell membrane. It prevents the peptidoglycan to stain on gram staining. So they appear as pink. Have you gone through this gram staining? because saffronin is a counter stain which stains red because the the stain, gram stain does not penetrate and stain violet with gram, but there's outer covering. Peptidoglycan is there. The structure is same, but it's thin and hidden. Clear?
Okay, thank you.
So,
Thank you, Doctor.
sorry.